Okay, guys, so Tammy here, and I have Bob with us as well today. We're going to talk, well, we aren't, he's going to talk about a couple more drugs relating to Parkinson's. Again, I hope you've enjoyed all the information he shared so far. And we're doing it through Zoom today, just so that we can have a little bit more of a conversational aspect to our time together with you today. So with no more me, I'm going to turn it over to Bob. And Bob, go ahead and share with what you have with us.
Hey, good morning, Tammy. Hello, everyone, and welcome. My name is Bob Fury. I am a pharmacist. And today what I'd like to do is talk to you about another group of medications that we use for the motor symptoms in Parkinson's disease. This group is known as the enzyme inhibitors. And there's basically two categories that we need to cover when we speak about this group. The first one that we're going to discuss today is known as the MAO-B inhibitors. And there are three drugs in that category. The first is selegiline, also known as Eldepril, which is its brand name. The second is rasagiline, known as Azilect, and a relatively newcomer called safinamide, who goes by the name of Xadago, and that came on the market in 2017. So that's category number one. In category number two of these enzyme inhibitors, we have a total of 4 drugs. The first is called entacapone, which is brand name Comptan. The second is tolcapone, who goes by the name of Tasmar. The third is Stalevo, and this is a combination product that encompasses entacapone plus levodopa and carbidopa, and I'll explain why they've done that combination shortly. And the fourth one is, again, another newcomer. It's called opicapone, goes by the brand name of Ongentys, and that came back down the market in 2020. So with that said, let's begin. Let's take the first group, which is our MAO-B inhibitors. So before we begin talking about an enzyme inhibitor, let's first kind of discuss what exactly we're trying to inhibit. So essentially, we're all very familiar with enzymes because we know they play a very important role in digestion. And enzymes can be found all through the intestinal tract, starting in the mouth. We have enzymes in our saliva. We have enzymes in our stomach. We have enzymes in our intestinal tract and colon, all for the purpose of breaking down our food to extract whatever nutrients that we need, whether it be protein, carbs, fats, whatever. Well, our brain also has enzymes. It's not just limited to the stomach. And one of the enzymes that are in our brain is an enzyme called monoamine oxidase type B. And yes, there is a type A, but we're going to specifically talk about the type B today. So the job that this enzyme has, this monoamine oxidase B, it has a very important job, and its job is to break down dopamine. It breaks it down into a very inactive substance, which ultimately just gets diffused out of our brain and eventually gets excreted out of our body. And when you think about it, that is a relatively important job because we can't just keep manufacturing dopamine, whether it be naturally through whichever neurons are still producing dopamine, or whether it's from an external source like our levodopa. Eventually, that dopamine would keep building, and having too much dopamine can be as problematic as not having enough dopamine. So the body needs a way of clearing out that excess dopamine, creating a new field for the next new transmission that's going to happen. So the job of these enzymes are important. But knowing that, what if we had a drug that could inhibit that monoamine oxidase enzyme from working? In other words, from breaking down the dopamine. Because if we had something like that, we would have more dopamine available to use. It wouldn't be broken down and turned into something inactive. Well, it just so happens that we not only have one drug, we actually have 3 drugs that can inhibit that use. And those are the three that I mentioned earlier, the elderpril, the rasagiline, and the sulfonamide. So let's talk about each of those and see how and why it really works. This group typically is looked upon more of a booster group because they're milder in benefit and they're very tolerable. And what I mean by milder in benefit is that you do get improvement in the slowness, the stiffness, and the tremors, but it's not as pronounced as you would see if you were using levodopa or if you were using a dopamine agonist. And that's why a lot of neurologists add this on as a booster to kind of smooth things out so you're not getting this sore tooth pattern of ups and downs so much. It helps to smooth things out a little bit. Now, because of the fact that they're so well tolerated, two of them, the selegiline and the rasagiline, they can be used as monotherapy or used all by themselves, especially in early Parkinson's. And that can be advantageous because for someone who does have early onset Parkinson's, we might be able to delay levodopa therapy or dopamine agonist therapy for months or years by using one of these enzyme inhibitors, particularly this MAOB group. So that's advantageous. The other thing too is even if we do have to add at some point levodopa to the therapy, it would probably come in at a much lower dose than if we were using it by itself because of the presence of this enzyme inhibitor. So all in all, that could be an advantage for a specific population of people. Side effects. What do we expect to see if we go on these? So the usual with this whole class of medication, the nausea and vomiting, sometimes that occurs, although they are relatively mild. Dry mouth sometimes is reported by a number of patients. That's fairly typical with this particular group, this MAOB inhibitor. Orthostatic hypertension. Now, I've spoken about this on numerous times, right? So that's going from a sitting to a standing position. We can get lightheaded or dizzy. I think all of us have felt that at some point in time. But for a Parkinson's patient, it could be worse, more severe, to the point that their pressure could drop very abruptly and they could perhaps lose consciousness and fall. And that's clearly something we don't want or need. So, but I will say that your neurologists are well schooled in this particular side effect, and they'll be monitoring that, your blood pressure very, very closely. And if it becomes an issue, we do have ways of working around that. Constipation can be an issue, which is always an issue, and it's just in general with Parkinson's. This may add to that somewhat. And some confusion and hallucination is not uncommon. However, that you typically see in the older population. You don't necessarily see that in a younger population. They are relatively convenient to dose, usually only once a day. In some cases, a patient may need to take 2 tablets a day, but that's really not bad in the scheme of things if we have to dose it that way. Now, up to now, I've been focusing mostly on the first 2 drugs in this group, which is the selegiline and the rasagiline. And I said that there is a newcomer, and that newcomer is called sulfonamide, whose brand name is Xadago. And it is a newcomer. It's only been on the market a few years. And in the drug world, that's considered relatively new. But it's somewhat different than the other 2. And what I mean by that is where the other 2 I said could be used as monotherapy or used alone, sulfonamide cannot be used alone. It is not FDA approved for monotherapy. It is only approved as an add-on to levodopa therapy, especially in those patients who are experiencing frequent or prolonged off time. The addition of the sulfonamide might again help balance that out a little bit, but not as monotherapy. Although, quite frankly, I would imagine at some point that's going to change. The sulfonamide, I'm sure the manufacturer is looking to get that indication as monotherapy, but since it's so new, we really need to see how it's going to perform in a real clinical setting and out in the general population but I would expect at some point in time down the road that that'll get clearance for monotherapy. The other unique feature with this is I've been talking about orthostatic hypotension as a side effect. With sulfonamide, we go in the opposite direction. This has the ability to raise the blood pressure. So that's something of concern, especially if you're a patient that's currently being treated for high blood pressure and is potentially taking high blood pressure medication. The addition of sulfonamide may elevate the pressure a little bit more. So again, the neurologists are well aware of this and they'll be monitoring your blood pressure very closely. And if it becomes an issue, again, that can be relatively easily addressed, either a dosage adjustment or an increase or something of that nature. With the sulfonamide, again, the dosing is relatively simple. It's generally taken only once a day. Again, that's very convenient. Most patients will start off at about 50 milligrams. And in approximately 2 weeks' time, the doctor will want to see you again and see how your symptoms are. And he may increase it to the 100 milligram level once a day. But typically somewhere between 50 and 100 milligrams would be the standard dose. The second group that we mentioned is this COMT or COMT inhibitors. And yes, the COMT does stand for something. I'll say it, but you'll see why we call it COMT. It stands for catechol O methyltransferase. So you can see why we conveniently call it COMT inhibitors. Now, although they are an enzyme inhibitors, just like the other ones, but they do things a little bit differently. The previous group, the MAOB inhibitors, they work by preventing the breakdown of dopamine so that we can increase the level of dopamine in our brains. This group, the COMT inhibitors, they stop the breakdown of levodopa, so we can get an increase in levodopa. The more levodopa we have, the more of it gets converted to dopamine, the more of it gets into the brain. So one group elevates dopamine, one group elevates levodopa. So they get the same effect, but they go about doing it slightly differently. Now, there are 4 drugs in this category, and let's kind of pick them apart. It was the Comtan, which is entacapone, tolcapone, Stalevo, and opicapone. I don't know where they come up with these names, but whatever. We have to deal with that. What's unique about this group is that the MAOB can be given alone. They can be used with the exception, of course, of that sulfonamide. But this group, the COMTs, are never used alone. They have to be used in combination with levodopa. And the reason being, for instance, if you just took entacapone all by itself without taking levodopa with it, you would see 0 improvement in any of your symptoms. It has nothing to do with improving Parkinson's symptoms, but it has everything to do with kind of preserving, kind of look of it as a bodyguard for levodopa. When you take your pill of levodopa, it gets bombarded. It gets bombarded with a whole host of things, but one of the things is this COMT enzyme. It wants to break it down the minute you take it, which we don't want it. We want it to linger around so we can cross over the blood-brain barrier and get converted to dopamine. So without levodopa, these drugs have no function. There's no purpose for them without levodopa present. And that's why they're never used alone. The second drug, Tasmar. Now, I'm mentioning this only for the sake of completeness, but personally, I've never seen it used. I've never dispensed it. And one of the reasons why it's not used much anymore is it ran into some trouble with toxicity, specifically regarding the liver. And it became known that it caused hepatotoxicity, and a handful of patients actually it was fatal for many years ago. And the drug quickly dropped out of favor. From what I understand, it is still available on kind of an emergency use only type thing, but you rarely, if ever, see it in practice anymore. So we're not going to spend any time on it. And Entacapone is really the one that's still available. Comtan, I've dispensed that many, many times. It's still in favor with a lot of neurologists. And it can be taken up to, boy, 6 or 8 times a day. And again, I'll emphasize it's taken with your levodopa. You take your levodopa tablet and you take your entacapone at the same time. They work together. They have to be administered together. Stalevo was one that I mentioned earlier, and that's a combination. It kind of saves the patient because it's already got the levodopa and carbidopa combined with the entacapone. It's all 3 ingredients in one tablet. And clearly that's advantageous for everyone. If you can get yourself stabilized on that dose, that makes life so much easier rather than popping pills all day long. So that was a nice addition when that came out. And the fourth one in this group, the opicapone, as I said, that just came out in 2020. This is also another nice advantage because it's only dosed once a day. It's a long-acting capsule, and it's to be taken at bedtime. Again, very convenient as well. The only thing with this is it needs to be taken on an empty stomach, although I don't see that as a problem. Most of us are not eating immediately before bedtime anyway, so I don't really think food's going to be an issue. And you need to take your levodopa within an hour before you take the Ongentys or an hour after. So you have a 1 hour window, but you must take your levodopa with it an hour before or an hour after. The side effects for these are all going to be the same that we've spoken about. There really isn't, and there's no change with the side effects with this group as there was with the MAOB inhibitors. But I will mention something unusual with the entacapone or Comtan. Unlike all the others, which can cause constipation, this one seems to go in the opposite direction for a small group of patients. Somewhere between 5 and 10% of the patients will experience diarrhea. And for some patients, this may be a blessing in disguise, knowing how battling constipation can be. But for some patients, it can be a serious problem. So if it is, that's one side effect that needs to be reported to the doctor. And they can make changes with the medication, either in the dose or change it or something like that to correct that problem if it becomes problematic for you. The other unusual side effect with entacapone is the pill itself is orange and it can stain. If you leave it on the countertop while you're going to get your water or something else, it may stain your countertop. It will discolor bodily fluids, saliva, urine, perspiration, anything like that can be discolored into a bright orangey color. The other thing is when you take it, just check and make sure that the integrity of the tablet is intact. In other words, if it's got a crack in it, don't crush it, chew it in any way, because if you do, you may actually, if you have any kind of partial or denture problem, it will stain the denture as well. So when you're swallowing the tablet, make sure it's fully intact. Now, I mentioned this discoloration factor, not that it's of any concern. This is a typical harmless side effect that occurs. It's not something that's dangerous in any way, but it's noteworthy enough because the first time you take it and you run to the bathroom and all of a sudden your urine is bright orange, it's not an indication that you're seriously dehydrated or you have some kind of bizarre problem. It's a very harmless, safe side effect that occurs to this. So with that in mind, I'm going to leave it there. We've covered pretty much all of that. I hope you've at least learned one new thing about this group of enzyme inhibitors, and we'll see you on the next one.
Awesome. I just had this mental picture of me taking, working out, and all of a sudden sweats of like neon yellow, neon red, or orange coming out my head. And I'm like,
yeah, that's true. And it can, and I can tell you even tears, if you were to cry or if you were tearing, cutting an onion or something, that could potentially come out orange as well. And again, like I said, it's a harmless side effect, but it can really scare you for the first time if you're not expecting it.
Or scare somebody else. You turn around and you're.
Yeah, exactly. That's right. Someone else. That's right.
Yeah, that's funny. Well, so real quick, that was really good information, and it's cool. Like I like the whole analogy about the bodyguard for the levodopa. You know what? I think I have the answer to why they named those pills or those drugs what they did, because three of them
All right.
sound like mobster names. They all sound like Al Capone's cousins. And the other one sounds like the Tasmanian devil who's no longer around, right? So like,
Yeah, kind of. And it's funny, when the Selegiline brand name of Eldepril, for the elderly, as I guess is how they came up with that brand name for that. And interestingly enough, a lot of neurologists are very comfortable using this drug, especially in an older population. I've heard of neurologists using this in patients all the way into their 80s because of its milder side effects. Sometimes they feel very comfortable, and the older population oftentimes presents challenges for using some of these medications because they seem to be more prone to a lot of the other side effects, where some neurologists aren't afraid to use these MAOB inhibitors in an older population. So I'm guessing that's really how they came up with the brand name Eldepril for one of them anyway. But it is a nice option for some patients, clearly.
yeah, it's cool. It's cool that you can do things to like preserve whatever natural dopamine you have, and then also to save the integrity of the levodopa. So that's great information. Great information there. So thanks, Bob. I think your face is frozen on my computer. I hope I can. Okay, cool. You just got a little froze there.
Yeah, of course. Yeah, yours too.
Okay, good. We're both
But yeah, so we've got more coming. Stand by for that. We have a few more drugs and drug categories that we need to cover for sake of completeness. We've got a few under our belt so far, but there's definitely more coming.
Yeah, absolutely. I love it. And I've learned so much. In a couple of videos down the way, we'll do more of a Q&A. So because I have lots of thoughts and lots of questions, and I'm sure everybody else does as well. We always want to encourage those thoughts and questions. Bob's been in the pharmaceutical business for how many years? Like
40.
Yeah. So you got a lot of knowledge there, and I love it. I've learned a ton in our little time of knowing each other. So thanks again. Thanks for taking time out of your schedule, and we'll talk soon.
Great seeing you. Take care. Bye-bye.